Welcome to Behavior Support Rounds. This is the monthly edition of our education offerings from Behavior Supports Ontario in Toronto Central, as well in collaboration with our CLRI colleagues and sponsored by Ontario Health. We are so happy today to have a wonderful colleague of mine, Sangita, here, who I'll introduce in a moment. We're going to be focusing on COVID-19 and specifically supporting healthcare providers in their mental health. So we're so fortunate. We all know we're still in recovery mode from our pandemic, and this will be really beneficial to thinking about how we can better support our teams, all our staff members, and so welcome. Just before we get started, we always base ourselves with an understanding that although we're meeting virtually, we're acknowledging that Baycrest and our related Toronto Central Behavior Support programs operate on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years. It's including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples, and we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, Métis peoples, and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You, of course, may work and live in different territories, so we encourage you to reflect on the land in which you are located and to consider your relationship with the land and the people who are the traditional keepers of the land. So some housekeeping things. Everyone's microphone will be muted. We have a wonderful telemedicine coordinator, Agnes, who's online. If you have any technical difficulties, please feel free to reach out to Agnes on the chat or directly. This event is being recorded, and what happens is we post it on both the CLRI and BSO Toronto Central websites. So if you have staff and colleagues who would benefit from this webinar, please feel free to share the links when they're posted with your colleagues. We're going to have opportunities for questions, chat in the Q&A section of today. So first, Sangita will present, and then at the end, I'll happily moderate the questions and answers. And lastly, if you would like a certificate of attendance, make sure that you complete there's an emailed evaluation. So please complete the emailed evaluation, which will allow you to put in your contact information, your email address into that. So can do that. In addition to the emailed evaluation, we will also have a poll that pops up at the end of the webinar. Please complete the poll because it helps us to understand if it was effective and how we can do better. So with that, I'm very happy and excited to present Sangita Singh. She is an OT by background. She has both an undergraduate and master's degree level. She's also the clinical research coordinator at McMaster, and specifically in the Psychiatry and Behavioural Neurosciences division. And as a side note, Sangita is wonderful and was previously a PRC and a behavior support specialist, kind of inaugural role at McLaren. And I have lots of years of experience with Sangita, so we're thrilled to have her on board today. I'm going to stop sharing so that Sangita can share her slides and we can get started. Thank you.
Thank you so much for that warm welcome, Jordan, and thank you for the love I'm already feeling from the participants. Really appreciate that. It's lovely to see some familiar names. I'm just going to switch this over. So I'm hoping to spend about 30 minutes talking about our research and then opening it up for discussion with the group. I have no disclosures. The project that I will be presenting on today was funded entirely by the Public Health Agency of Canada. So again, no commercial support and really no conflicts of interest to declare. All the resources and the study itself is evidence-based that I'll be talking about in a minute. So as Jordan said, today we're talking about you, the healthcare providers who served so incredibly through the pandemic, and what we are seeing in the research, why this is important, and hopefully some things we can do about it. So our goal today is to define the concept of moral injury, review current evidence on healthcare provider mental health and the impact of serving during the pandemic. Sorry, I'm just moving the bar a little bit so I can see my screen fully. And explore evidence-based mental health resources to support healthcare providers and teams. I'm going to start by playing a short clip from a video. This is part of a series of deliverables that we created for the project, interviews with healthcare providers from across the country and their experience of serving during the pandemic. So here we go.
I used to blame myself a lot. I was supposed to be their caretaker, and I couldn't take care of them because I couldn't even take care of myself. My name is Krisha. I'm an RPN, registered practical nurse, and I was also a nurse manager at a long-term care home. I help patients and staff with managing the symptoms of dementia. In early 2020, we were hearing the rumbles about COVID-19. There was a patient who had like a fever, a cough, and like their oxygen started going down. And we self-isolated that person. So the next day, we were all crying because we know exactly what was happening. We were not prepared. We didn't have PPE. All of our face shields were expired. All of our N95s were expired. We couldn't even reorder them. We didn't even have face masks. So we were kind of like, this is like, it's finally here. You know, we're so scared. Like, that was the first time ever in my career that I was scared. I was scared to be a nurse.
So that clip, hopefully, I think represents, captures a little bit of what healthcare providers were telling us from across the country of some of the anxiety, the fear, the uncertainty that they were facing as the pandemic landed on Canada's shores. And what we saw during the pandemic was care needs shifted. And mandates, expectations, and role changes happened literally overnight and several times over the course of the pandemic. And essentially a new normal was created, but with the same expectations of as the past in terms of providing service and quality of care. So what we saw was the emergence of what has been referred to as COVID-19's signature wound, moral injury in healthcare providers. And moral injury was first actually described in combat soldiers, and it was defined as the psychological, social, and spiritual distress that results from experiencing a violation of deeply held morals and values. Simply put, it is the emotional consequence of not being able to do the right thing. And it's a response that we see that emerges in situations in which the individual acts or does not act in a way that violates their morals and values, witnesses the actions or inactions of someone else that violates their morals, and or experiences a betrayal by a trusted authority. Moral injury has significant mental health impacts. It has been documented and researched to show it increases emotional distress and suffering, feelings of guilt, demoralization, shame, and anger, increased risk of anxiety, PTSD, and depression symptoms. People tend to ruminate over the decisions that were made or not made, so thinking over and over about what ifs and should haves and could haves. People experience sleep disruption, insomnia, feelings of worthlessness, helplessness, and powerlessness. Self-isolation has also been observed, avoidance, loss of trust, self-blame or blaming others. They can, in severe situations, people experience impairment of functioning, increased substance use, and potentially increased suicidal risk as well. So why is this important? We know right now, it's being talked about in the media as well, healthcare providers are leaving their organizations and their profession due to moral injury and moral distress. What has been shown is that moral injury and moral distress strongly predict PTSD, post-traumatic stress disorder. And in fact, the combined impact of moral injury and moral distress can significantly explain 87% of the variance that we see in PTSD symptoms. What we also find is that increased organizational support is associated with reduced MIMD. So I'm really grateful to have this opportunity to present to all of you, because this is organizational support as well, with Baycrest supporting the delivery of this information and this content to healthcare providers who are doing direct care. So what I'll be talking to you about today is the project that was called Healthcare Salute, and that's the title of it, Healthcare Salute. Thank you for your service. Our principal investigator loves long titles, so the full title is Healthcare Salute. Thank you for your service, an ongoing surveillance and knowledge mobilization plan to support the needs of Canadian healthcare professionals impacted by the COVID-19 pandemic. So this was a mixed method study. We were doing quantitative surveys and data analysis, trying to capture mental health correlates for healthcare providers, and simultaneously conducting in-depth qualitative interviews. And the goal was really to get the research together in order to develop and disseminate evidence-based mental health resources that were specifically targeted for healthcare providers. So in our study, what we found was that healthcare providers experienced potentially what are called potentially morally injurious events during COVID-19 in Canada. And some of these events were witnessing patients dying alone, having to stand in with these patients as family members, repeated deaths, and not having the time to process the grief of witnessing those deaths, the provision of futile care, feeling like the care that they were providing was not going to help, feeling like their professional opinions were being ignored, witnessing patient harm, bullying, violence, and divided opinions, the resources and personal protective equipment that was talked about so much, especially in the early days before we got the supply chain organized, but that created a lot of distress and anxiety and fear in healthcare workers, especially in the face of a virus that we didn't know much about at the time. Increased workload and decreased staffing and conflicting values. In addition, a number of healthcare providers talked about some non-work related stressors as well. So exhaustion and burnout, but feeling like they were undeserving of time off or rest because they felt like they were letting their colleagues down. That fear of transmission of the virus to themselves or to their family members and others, disruptions in their family life due to increased work hours and living apart for safety. There was a lot of concern about traumatizing others who were not healthcare workers. So that kind of took away the opportunity of being able to talk about their experience to other people and sort of resolve and decompress a little bit that way. Some healthcare workers described to us that they felt like they were living in a different world than non-healthcare workers, and really felt like they were not understood. And in addition, they also talked about the loss of their usual coping strategies. So many of you at this point may be thinking, I experienced all of that. The important thing to note is that while people may experience moral injury, not everyone, potentially morally injurious events do not lead to the experience of PTSD. There are many other factors that come into play that can either exacerbate or mitigate the impact of potentially morally injurious events. So this was the study, and we did see the impacts overall on mental health of healthcare providers in our diagnostic test, screening test that we were doing. We found that 1 in 3 healthcare workers, 32.8%, met the criteria for a probable diagnosis of PTSD, 63.4%, so 2/4 almost reported clinically significant levels of depression, 56% reported clinically significant anxiety, and almost 60% reported clinically significant symptoms of stress. And more importantly, and this is sort of reflecting these figures around intention to leave, are reflecting other studies that are happening across the country, as well as what we are seeing in terms of human health resources across the country. 3 in 5 identified that they were quite likely to leave their organization within the next 6 months. And 2 in 5 were actually considering leaving their profession altogether. So these numbers are based on about 1,264 surveys that we had done as of February 2023, and more than 150 in-depth qualitative interviews. So fairly significant findings here. Going back to the coping strategies that we were talking about earlier, healthcare providers in our interviews said that they took shifting approaches to coping, and some were actually able to find new ways to cope. So healthcare providers talked about taking up new interests, cooking, knitting, activities that they could take on despite the restrictions that the pandemic was imposing. A number also identified the quick fix option, and this was more chips and pop or binge watching Netflix. And they recognized that they were not, these were not healthy coping strategies, but many of them talked about the fact that this was all that they felt they had capacity for. And it was the only way they could sort of decompress and compartmentalize some of the work experiences that they didn't want to bring home with them. In terms of barriers to desired coping strategies, healthcare providers told us that the pandemic-related restrictions took away a lot of their usual coping strategies. So people talked about gym closures and not being able to go to exercise as a way to decompress. They talked about the social restrictions, and especially as frontline healthcare providers, they really didn't want to risk transmission for their loved ones. And essentially what that did for them was it took away the opportunity for social engagement and networking and being able to give and receive affection, which has such a huge impact on our emotional health. In terms of circumstantial barriers, healthcare providers talked about communication barriers with friends and families. And for some of them, these became more exaggerated and exacerbated as the pandemic progressed. And this was really around things like politicized views. And people felt that their social network in some instances did not understand. Healthcare providers didn't want to traumatize their social networks by talking about the work and what they were actually witnessing and experiencing at work. There was just so much exhaustion by that point. People just did not have the energy to be able to bring all of this up and be able to talk about it. And there were seasonal barriers as well. So wintertime made it even harder to try and figure out how to find ways to engage in usual coping strategies. So having all this understanding from our research really guided the development of our knowledge resources and the tools that we were building for healthcare providers. We had two key goals for this project. One was to develop evidence-based mental health literacy tools for healthcare providers, so that they would know to recognize trauma and PTSD and to know how and when to seek help. And the second was to develop evidence-based guidance and training tools to equip healthcare providers, supporters, and organizations to respond safely and effectively. Very interestingly, in some of our qualitative interviews, healthcare providers talked about accessing EAP to get some mental health resources support. And they talked about the fact that being able to talk about their experiences to these counselors was a challenge, because sometimes once they started talking about what they were experiencing and living through, counselors would break down and start crying. So really it was to build occupational cultural competency in mental health supporters who were working with healthcare providers to help them understand a little bit better what the work context of healthcare providers has been through the pandemic, so that they could serve them more effectively. So again, talking about applying the research to resource development, having that understanding of healthcare provider experiences, their lived experience, as well as the work context, really was the foundation on which we built all of our resources. Everything is presented in plain language. It's available in English and French. It's all online, asynchronous, and self-directed. We know people are working shifts, so we want it to be as flexible as possible. The content has been chunked for quick reading, so 5 to 7 minutes, sometimes even less. There's a big knowledge to practice focus, so interactive exercises and activities to help people to take what they are learning and practice applying it into their own lives. In addition, we had a healthcare provider consultant panel and a knowledge advisory committee that reviewed all the content for us as we were building it and gave us very rich feedback, so that we could really target on keeping it at what was most important and effective. In the healthcare provider panel, we had a nurse who would save the content that she was reviewing to read after she finished her night shift. And we were so grateful for that, because she was really trying to make this experience as real and in life as possible. So when she came back with feedback, it was usually to say, chop this down by 7 pages. So we really appreciated that. So in terms of knowledge translation resources for healthcare providers, we have mental health literacy tools, fact sheets, information sheets, mental health continuum model assessment tool where you can almost do a pulse check on your mental health. There is a stress, trauma, and PTSD psychoeducation program, which is very introductory. And the idea is to just get healthcare providers grappling with the fact that the work that we do is hard, and stress, trauma, and PTSD are very much a lived phenomenon and a reality for healthcare providers, even though we don't use that language for our work experience. There's also a deeper dive curriculum on moral injury and moral distress. And to the right, what you're seeing is a graphic from that curriculum, which helps to, which is based on acceptance and commitment therapy. It's called the Matrix, and it guides the user to help them shift their thinking to come back to what is most important and help the user to live from a place of values. In terms of our resources for leaders and organizations, we have developed an organizational recommendations document for healthcare organizations. There's also an introduction to trauma-informed care for non-mental health care providers. And on the right, you see a screenshot from that trauma-informed care curriculum. we built a bunch of resources which actually address both goals. So that clip that you saw from the beginning, at the beginning of the presentation, is from a national series of interviews that we did with the Media Girlfriends, who are an incredible group of journalists. And that's interviews with healthcare providers from across the country. We also hosted symposia and town halls, and everything is saved on our website. We also have a YouTube channel. So the Word file that Agnes shared with you at the beginning should have links to all of the resources, as well as to our website and our YouTube channel. In terms of future directions, we have received additional funding, and in the coming year, we are launching the phase 2 of our research, where we are focusing much more on leadership and organizations. We will be offering a free online symposium in the winter, so we hope you will sign up for that and attend. We've had really good attendance in the past, and lots of rich discussions arising as a result of that. We are hoping to launch in the fall a social media campaign for healthcare providers, which we are calling Care for Carers. And in the winter, a You Are Not Alone campaign, which will really be to express our gratitude, our awareness, and thanks for the work that healthcare providers are doing. And we're hoping that that will become that will snowball into a larger movement, because we want to get the word out about the work that healthcare providers do and how important that is for all of us. Individually, I would recommend, if I have recommendations to make, and this is based on my own learning on working in this project and over this past year, is for healthcare providers to prioritize their own health and well-being. And we, in our interviews, have found healthcare providers have been talking about the things that they found really helped them: spirituality, family, social networks, and setting aside time for self-care. So I would invite and encourage you to make that a habit, because healthcare providers, our culture does not necessarily, we tend to give and don't expect to get back. And our well-being is a limited resource. So we need to charge and recharge ourselves, and do that in an intentional way. I invite you to sign up for our newsletter so that you can keep updated with the research that is happening and events as they come out. And I encourage you to be the change. So participate in our research, and on our website, there is an opportunity to sign up for research projects as they come up, because we are in the process of, my principal investigator likes to say that understanding of mental health for healthcare providers lags by about 10 to 15 years behind military and veteran personnel and public safety personnel. So we're in the process of building that evidence to show that healthcare provider work is hard. And we would love to have you contribute to building the body of evidence so that we can then advocate for formal supports at the system level that are so needed for healthcare providers. Those are my references, and that is it. Thank you so much for your service. I'm going to stop share, and we can open up for questions.
Thank you so much, Sangita. I just invite everyone, if you can, to put your questions in the Q&A. This is a webinar, so we're not able to do things like unmute and have an active discussion, unfortunately. So feel free to put any questions into the chat box, and we will read them out for everyone. So Callie asks, I noticed the reference to ACT, or acceptance and commitment therapy. Is there somewhere on the website that shows some literature regarding application of acceptance and commitment therapy?
Great question, Callie. And we are still, so I should have mentioned this earlier, so I'm so glad you asked. for that question. We're still in the process of building the website. We've literally built it from scratch and had to have it live by March 31st. So we managed to do that, but in the process are still adding to the content. And we hope that everything will be fully operational by mid-September. And we are planning to have some information there on a video clip on how to use the matrix. There is a tutorial on using the matrix. There are references there as well for people who want to do a deeper dive in assessment and acceptance and commitment therapy to learn more.
Great, thank you, Sangita. Yes, please add any references, that would be great. There's a question in the chat box from Edgar who says, any experience with peer support groups?
Great question, Edgar. So our project was not actually working on building peer support groups, but as part of the funding that the FACT project received, and I think what I'll try, if I can, I will do this. I'm going to Safer Anagram Institute. There's the Canadian Institute for Public Health Education and Research, that's CIPHER, was an institution that was set up by FACT for pandemic health education, and I always get confused, pandemic health. So this was an institute that was set up by FACT, and they are sort of a knowledge hub. And some of the spoke projects, one of the spoke projects that was funded by FACT was specifically looking at peer support. So if you Google Cypher Canada Institute, I think you should be able to find it, and that will take you to the website where there will be more information on the peer support project as well.
Wonderful. I have a question. Edgar says thank you. So I have a question, which is, how have you found the resources that you developed to address those two goals? Like, what's the receptivity of those resources? What's the use of those resources? Are you finding a lot of uptake?
So this is part of the dissemination plan, because does anyone, if everyone remembers Field of Dreams, right? The message was, if you build it, they will come. That's not true. We know that in knowledge translation. So really getting the word out. And I really invite you to join us on LinkedIn, because we are trying to organically build our base of, on the products that we are developing, the resources that we are developing. We have had, what we've noticed is every time we go out individually, and it's hard work, but we're happy to do it, literally meeting healthcare providers in groups and forums such as this. That's the only way to get the word out, because just to build a website and then expect people will show up, it does not happen. So we have been getting traction, and we're hoping that as the website becomes more and more operational and people start to see that it's useful and tailored for their specific healthcare need or mental health needs, we will see more and more update there.
That's wonderful. Thank you, Sangita. And I know we have people from lots of different organizations on this video, so I really encourage people to share the resources that Sangita has shared with your organizations, and especially with your leadership, because although it's amazing to talk to all the individual care providers, it would be great to have organizational support to really make sure these kinds of resources and approaches are disseminated. So if you have opportunities to share that with your organizational leaders, I think that would be wonderful.
Absolutely. And actually, that was one of the things that really came out for us, which is why when we applied for extension funding, we specifically said we wanted to work at the organizational and leadership level. The challenge for healthcare in Canada is that because we are publicly funded, funding dollars are tied to care. And I think what the pandemic has made really clear is that we need to, unless we take care of the carers, care will be affected. And, so at the organizational level, the goal eventually is to push for system change and get the kind of resources and supports that are available to veterans, to military personnel, even to public safety personnel. So police, fire, ambulance all have typically much more enriched mental health supports than healthcare providers do. And that's a system level issue. So we really need to build evidence to show that these supports are needed because the work is not easy.
Oh, that's so exciting and music to our ears, I'm sure. There's some comments here I'll read out because only the hosts and panelists can see them. Trevor just mentions that he's feeling very validated, I think. He's so glad that someone is recognizing what healthcare workers went through the pandemic, and that a lot of supports resources fell away despite everyone trying their best. So just thanking you for your work. And Jennifer says that it's hard to retain healthcare workers, as you said, that many have left, and also this is part of attracting new grads and other people to healthcare. So she was asking, are healthcare organizations using these resources? How do they use them to recruit and retain?
So that's the hope, Jennifer, and that's what I'm hoping that we'll be able to do with these presentations. And my team and I are happy to make as many of them as we can, knock on as many doors as is needed, because just building the website is not enough. Actually going to people and talking about them. And I think this is really sort of a cusp moment where there's an opportunity for change, because the health care worker human resources crisis is such a real one. I think there is engagement and there's an opportunity to say, unless we change the work context and the supports that are available for healthcare providers, the system is in real danger, and our ability to care for Canadians is in real danger.
Very good point. Thanks, Sangita. There's two other questions, one in the chat and one in the Q&A. So I'll read the chat first. Edgar asks, how is moral injury different from burnout or emotional exhaustion?
Great question. So that's a conceptual difference, Edgar. Burnout has been traditionally seen as an individual response that people are experiencing because of pressures and stresses from their work environment. It was typically associated with service environments. I think Maslach, who has created the definitive burnout inventory, and I'll get it wrong because it's been such a long time since I saw the inventory, she defined it along 3 factors, 3 or 4. So there was emotional exhaustion, depersonalization, and I cannot remember the third, but if you Google it, you'll find it. Moral injury is really the impact of things that are happening around you that may be being done to you. And this is why we were talking about the concept of moral injury earlier. It's not necessarily something, well, it can, an element of it is certainly what a person can or cannot do, but it's the context. So both PTSD and moral injury, unlike other mental health conditions, can be directly associated to what's happening around the person. And that concept, that idea of betrayal is a really powerful and important one here. People who have experienced moral injury talk about that sense of betrayal that they feel when people around them, trusted people around them, fail to do what needed to be done. And it's that conflict with one's own morals and values that creates that distress that is so very different from burnout.
Thanks, Sangita. And Magdalene asks, thank you for your work. She says, as a staff at mid leadership, she wants to make changes, but it's difficult. I guess her own, I guess, values and possible moral injury are coming in here because they don't have things like funds or other resources to put some of these things into practice. Are there any suggestions you have, or I guess the overall question is, do you need to have other extra resources or things in order to adopt these practices?
Yeah, no, great question. And again, I think it goes back to that. It's fantastic that we have a publicly funded system. But these are also the challenges that are experienced in a publicly funded system, that traditionally the workers themselves have not been included in that equation of what are the supports that workers need in order to function well. And that applies to workers through every level of the organization. And this is the reason why for phase 2, we wanted to look at the organizational and leadership level. Because even the healthcare providers that we interviewed talked about the fact that they were aware that their leadership was under a lot of stress. Policies were coming from outside at the system level to the organizations, and then it was the leader's job to disseminate it to healthcare providers. And healthcare providers talked about the distress that they felt being made the face of these policies. So for instance, no visitor policies, right? That was implemented to keep everyone safe, but healthcare providers talked about how distressed they felt in being that face of the policy, of standing in front of the grieving family who had been told that their family member was not going to survive, but they could not let them in through the doors. And we heard of instances where middle management stepped in to take on that role from overburdened healthcare providers, and the impact it had on them as well. So what we are hoping in the second round is to explore some of those themes that started to emerge for us in phase 1 and be able to develop more resources for healthcare providers. I think one of my biggest learnings has been that just as a healthcare provider myself, I'm now in my 3rd decade as an OT, and working on this project really made me think about the things that we take for granted, what is left unspoken in healthcare culture. And learning about moral injury was like this huge eye-opening experience for me, because it made me think about the times when I didn't cope and or felt I wasn't coping in my own practice. And the general understanding, which I internalized in myself as well, was the fact that, oh, I'm not coping well. And just having someone else say to me, the research shows healthcare providers are doing hard work. We do clinical care, but we also do a lot of emotional labor, right? Because pretty much everyone we work with, interact with, is coming to us in distress. And processing that while giving care, taking care, that takes an emotional toll. So downstream, down the road, what I'd love to see is, along with clinical courses, self-care is made part of professional training, and it's embedded in the culture. I was astounded when I heard that for ambulance workers, if they've had a very difficult call, they can come back, and their work now, there's space there where they can take 45 minutes off the shift. And there is 24/7 support available of trauma-trained counselors where they can pick up the phone and make a call and get instantaneous support. That sounds like a dream in the healthcare provider context, right? Like to take 45 minutes off the shift because you had something really challenging happening. And that's the culture change we're hoping that this evidence will start to build, to just give us that agency to recognize this is hard work, this is not easy, and the work itself and the context in which we are providing it has impacts on our mental health, and we need to take care of ourselves.
Thank you so much, Sangita. I really appreciate also your openness about your own experience, because it helps to, normalize and destigmatize that, that experience as a healthcare provider, for sure. We're going to take this last question, and then we might wrap up the Q&A section for today. This person is asking about overtime and the amount of overtime that people had during the pandemic, often because of HHR shortages. People from every level of healthcare were asked to do overtime. And sometimes that overtime was not acknowledged with extra compensation or lieu time or vacation offered. But simply, we heard over and over again in the pandemic, like, your healthcare heroes, like that sort of, which is great to hear, but like without a lot of other things. So I think every organization has different unions or non-unionized things. I think this is a complex topic, but any comments about, the request of people to do kind of superhuman amount of hours for long periods of time?
Yeah. No, that's Jordan. I think just in outlining that question, you have really fleshed out some of the complexities, which at present make it so difficult to say, here's the solution. I hold out hope personally, because when I joined the research team, I was still just coming out of the clinical field, and I was like, this change is never going to happen. But looking at how shifts have happened and the possibility for culture change. So the military, for example, in the last, I would say 10 years, they have engaged in a lot of effort around things like military sexual trauma. It took advocacy, it took a lot of research. And as the evidence builds up, it becomes harder and harder to deny. So hopefully we will get to that point where we can talk about it. There's enough evidence to say these supports are needed. Healthcare providers are taking care of all of Canada, all of us, right? And I think the pandemic really pointed out that when we take care of those who are most vulnerable, we take care of ourselves. So I think speaking back to about healthcare heroes, I think, as our research progressed, some of the moral injury that healthcare providers were talking about was the shift that happened in the social context, right? So we started out banging our pots and pans, and by the end of it, the truckers' convoy was going through, and healthcare providers were being talked about as though they were peddling conspiracies. So that felt like a huge betrayal, and all of that. We need to process all of that and come to grips with it and work forward as well.
Thank you so much, Sangita. I'm going to wrap us up for the end of our Q&A session. I think this has been really great questions, and thank you, Sangita, for these really well thought about answers. I am going to thank you for Agnes to put up the poll. We will be sending out the evaluation to you guys by email. Please complete it if you can, if you'd like that certificate, and even just to give us feedback. I see lots of people thanking you, Sangita, and lots of emojis coming up, because this is, I think, a very pertinent topic that pulls on the heartstrings and means a lot to everybody. So with that, I thank everyone for their time, and please join us again next month when we have our next behavior rounds, always the third Thursday of the month from 2 to 3. So please save that time in your calendars, and thank you again so much.
I just want to say thank you so much for inviting me, letting me join you for this session, and thank you so much, all of you, for your attention and your wonderful, thoughtful questions. Thanks.